Yeah, if you sit down, I'll bring you up. Good morning. I would like to welcome you all to the 6th Philip Cryer Lecture. Dr. Cryer was a very accomplished endocrinologist and teacher whose career focused on patient-oriented research. His many contributions included the discovery of hypoglycemic unawareness, which has led to the development of life-saving therapeutic approaches for this condition. Dr. Cryer passed in February of this year. Today, we're joined by two of his children, Phil and Justine Cryer-Dugan. Would you please stand so that we can recognize you? We appreciate you all for joining us as we honor your father's legacy. I'm also pleased to introduce our speaker, Dr. Sue Brown. Dr. Brown is the Gerald D. Auerbach Professor of Endocrinology at the University of Virginia. Dr. Brown did her undergraduate studies at UPenn and her MD at UVA. Her internal medicine residencies and fellowships were done at UNC Chapel Hill, where she served as faculty prior to moving to UVA. She is currently a member of the UVA Center for Diabetes Technology, where she works with engineering and clinical research teams in translational studies for the treatment of diabetes, specifically automated insulin delivery systems. She has been a principal investigator on several NIH-funded and FDA-regulated clinical trials that focus on those with type 1 diabetes. Her work has led to the use of 2 currently approved AID systems. She is also the PI for NIH grants that work to eliminate the need for carbohydrate counting to reduce the significant burden on those with type 1 diabetes by developing a fully automated insulin delivery system. In addition to her significant contributions through research, she has been awarded multiple awards for medical education, mentorship, and patient care at UVA. Please join me in welcoming Dr. Brown.
Thank you very much, Kai, and it's such a pleasure to be here, and it's a true honor to be here in honor of Philip Cryer. So nice to meet your family, and I am so glad to be here speaking with you today. I'm going to be talking about, I guess I'd say bone is my first love, because I did start in the bone field before I was in the diabetes field, but my second love, I guess, which is some new advancements in insulin delivery. It's focused on treatment options for glycemic control. These are the disclosures, and I thought this was a little hard to see, so I just you can see I have no personal disclosure. This is research support to UVA. So today what I'd like to do is review one key technology, which is continuous glucose monitoring, and I'm sure many of you are familiar with CGM use. We'll review what the role is there and how those devices perform. And then I want to discuss how that relates to automated insulin delivery devices. And I suspect a lot of you would be less familiar with that. Endocrinologists, of course, would be. But, and these are really becoming standard of care devices for the management of glycemia in type 1. And I want to just touch on how technology use may relate to healthcare disparities, and conclude my discussion today about one particular application of AID devices, AID being automated insulin delivery, and that is in the inpatient setting. So with that, let's first begin thinking about type 1 diabetes, and it was the landmark DCCT trial in type 1 diabetes that really has established for us what the ideal treatment options are. And that is, that trial identified that intensive therapy really decreased microvascular complications. And by intensive therapy, that group that received intensive treatment options got an A1C around 7% compared to 9% in the conventional group. The reality of this trial, however, was that this approach to more intensive glucose control resulted in a 3-fold increased risk of severe hypoglycemia with intensive therapy. And again, as in honor of Dr. Cryer, he spent his career focused on the sequelae of hypoglycemia and what that means. And that does not mean that it's just an isolated event that happened yesterday. There are downstream effects of that. So this sort of sets up this big gulf. How do we, if we identify what our ideal is, the reality of that and getting there is really challenging. And if you ask someone who has type 1, what do they want? I would say, you know, they want their old pancreas back. And this discussion is not about islet transplantation, organ transplantation. But it is a question of, can we mimic a lot of what is missing in type 1? And I think individuals, they don't want to worry about hypoglycemia. Food flexibility, if you have type 1, you constantly have to think about everything that you're eating and planning for that and accounting for that. Blood sugar testing, who wants to check their finger stick very often? Sports activity can be challenging. And I think most people, just want to sleep at night. One of the most fearful times is thinking about hypoglycemia overnight, either as a parent or as a person who has type 1. So there have been a lot of development of a variety of different solutions to this, and I just love this picture. I always just have to show it. Back in the 50s and 60s, we actually had an amazing insulin pump system that could regulate glucose quite well, but you can see here it's a backpack and it's got IVs and it's going into veins. And so that is not at all practical. That's not where we're going to head. But I'd like to share with you where we've come with this area and begin by saying that there's a big need. In type 1, our T1D exchange data, this is the big US registry that really informs us of how we're doing in type 1 management in the US. Only a minority really are achieving our ADA goals of A1C. I intentionally showed you a lot of this data that is just before the advent of the availability of some of the commercially available technology today. And only about 21% of adults are meeting our target A1Cs of 7%. And this is showing you over time. It's worse when you're a teenager, but it's still an issue as you get older. For those of you that are less familiar with continuous glucose monitoring, you're all familiar with A1Cs and A1C targets. When we talk about CGM-based, what we're looking at is goals of looking at time and target range. Most of the data I'm going to show you today is oriented toward this particular outcome, and time and range is defined getting glucose values between 70 and 180. And our clinical goals are to make sure that someone gets more than 70% of time in this target range. To do that, we want to minimize hypoglycemia. Hypoglycemia is when your glucose is less than 70 and certainly less than 54. And across the board, we want less than 4%, and some higher risk individuals we're going after 1% or less in this area. That's balanced again, hyperglycemia. In particular, the greater than 250, we really want to minimize that. So these are some of our glycemic goals today. This is true of type 1 and type 2. Time and target range, there's been a lot of work trying to demonstrate that outcome related to microvascular outcomes that we care about. This is data from the DCCT. They didn't obviously have CGMs back then, but they did do frequent finger sticks. And if you look at the incidence of retinopathy or microalbuminuria to microvascular outcomes, this clearly related. The more time and target range you get, the lower your risk is of these events. So I think it's a highly relevant outcome. Not only that, A1C is really a measurement of average glucose, mean glucose, and what it absolutely misses is the day-to-day glucose variability and the glucose excursions that occur. And this is really, a lived experience for an individual person. We think that may have some independent effects on some of the outcomes, particularly cardiovascular outcomes. So this is just showing you some CGM traces of two individuals who have type 1. They have the same A1C, they're 7.5%, but you can see the person at the top, panel A, is experiencing glucose down into the 50s and up into the 400s in a single day. This is a 24-hour snapshot here. And the person B is not experiencing those extremes. You can then identify this. If you look at a CGM trace of that, you can see person B is 77% time and target range and person A is only 60%. So I think these measures capture another element that's quite relevant for management of glucose variability. So then let's think about the actual devices themselves. If you look at technology use in this past decade, it is remained pretty stable in terms of insulin pump use. Again, this is the type 1D exchange registry in the US. But CGM use has really skyrocketed, and the newer numbers are much higher than this. So this is one tool that people are beginning to use. And when you're balancing monitoring and treatment options between glucose and insulin, obviously type 1 requires insulin, and you're balancing other factors, meals, exercise, stress, The techniques we have for glucose, the standard ones obviously are the finger sticks, and now we have the continuous glucose monitoring, or CGMs. For insulin administration, we have lots of methods of doing that: needle injections, pens, smart pens, insulin pumps. I'm not talking about insulins themselves today. There's a wide variety of insulins, including some new once-weekly insulins. We're all struggling figuring out how those might play into our treatment paradigms. But what I'm going to focus on today is just insulin pumps. And you see a couple pictures of them there. In terms of the CGM data, we'll look at that first. They clearly, in many studies, have shown improved glycemic outcomes in type 1. This is just one study, the Diamond study, showing a 0.6 reduction in A1C when using the device over 24 weeks, and a decrease in hypoglycemia. When you look at this same trial done in type 2 diabetes, you'll see less of a reduction in A1C in this particular trial, 0.3% reduction. And type 2 has a little bit less of a burden of hypoglycemia, so in a lot of these trials, we don't always see that it changes hypoglycemia itself. When you look at some of the meta-analysis for RCTs and CGM versus usual care for type 1 and type 2, routinely increases time in target range, routinely decreases hypoglycemia, hyperglycemia for type 1, and glucose variability, a little bit of that element of how much that glucose excursion goes on in an individual day. There's some areas that are really in need of a lot more work, and what that means, pregnancy being one of them. We finally have one CGM that is approved for use in pregnancy. Type 2, we're still trying to figure out exactly the role, and I'll show you some of that data. And then as I said, I'll conclude with some application in the inpatient setting. So what do these look like, the CGM technology? There's a lot of them. You just see some examples here, but generally it's a device that's worn on the arm or the abdomen, and it measures glucose every 5 minutes. So you'll either on an app on your phone or another device, you'll see what the values are. They're quite accurate in terms of trend. So very universally, even if the number isn't exactly spot on, the trend is really quite clear. There's even now an over-the-counter one, so people don't need a prescription. It's a 15-day wear glucose biosensor. When I looked it up this week, it was about $100 if you were paying out of cash per month. And that's technically not for people on insulin. The FDA labeled it that way. But for the prescribed ones, you see them here, and they're worn anywhere from 7 days to about 14 or 15 days till you have to change a new one or it falls off. And then we have one that was just approved for implantable for 1 year. It is not yet connected to a lot of the pumps, so you won't see a lot of us using it just so much yet, but there's more advancements in CGM itself. In terms of accuracy, they're generally measured on something called the MARD, or mean average relative difference, compared to a standard. A standard would be a serum glucose measured by YSI. And the modern ones are all in the same bucket. They're really less than 10% different. And I think that's well established as a valid measurement. But on this chart, you can see that we've had CGMs going back to the late 90s. Actually, they were terrible back then. But certainly in the last 5 years, they've gotten really quite good. And I want to just mention, because most people think, oh, our standard is finger sticks. Finger sticks are also an estimate, of course. And this is looking at the same 10% MARD. These are just some commercially available glucose devices that are glucometers that are out there. And you can see some of them perform great and some of them perform terribly. So there's a lot of variation in that. The FDA has very specific requirements of what they'll allow. And they are usually looking at 15% difference, trying to make sure that at least 90% of the values are within 15% of an actual YSI. So just a reminder, these are all estimates. And the trends really, I think, are critical. Okay, so with that, let's turn to automated insulin delivery systems. And let me just describe what these are. Essentially, they start with an insulin pump. Actually, I'm not sure if I have a... Okay, so you need some sort of insulin delivery device. In this case, it's an insulin pump. And this is going to result in, obviously, changing your glucose level. Next, you have a sensor that's sensing what is happening with your glucose level, and that's a CGM. So the person has two things on their body. They have a CGM that they're wearing that they change every 7 to 14 days. And then they have a subcutaneous catheter that's where the insulin pump is delivering insulin, and those are changed generally every 2 or 3 days. The key piece to kind of what we call closing this loop is this algorithm. So that's just a fancy term for a whole bunch of equations for how to figure out what our targets are, how to figure out how you can get enough insulin to meet the targets, and what's happening on that individual person. So driven mostly by the CGM data and the insulin data. So the algorithm, generally every 5 minutes, will make a new insulin dosing decision. So when someone is wearing these devices, every 5 minutes, a new decision is made. It's forecasting what's going to happen in the next 30 minutes, 45 minutes. Are we going to meet our target, and how do we need to adjust insulin to get there? So 24 hours a day, it's working on getting where the person needs to be. So that's the general idea of the automated insulin delivery. They're not fully automated. The person, for sure, has to manage these devices, make sure they're working and they're talking to each other. And they perform much better if someone informs the system of a meal, tells the system that I'm going to eat, this is how many carbs I'm going to eat, and you get specific insulin or user-directed insulin boluses for that. So they're not just put them on and let them go, or at least the state of the art. We are working on the ones that will be like that. But the current ones are not that. Here are some pictures of them. We have just even in this past year, 2 were approved and 3 the year before that. So they're now becoming a plethora of them. And generally they have, again, the CGM you're wearing, they have either a pump that's attached to you or on your body, and they have a lot of phone apps that people can bolus from. There's also some that are not yet, don't have devices yet, but have approved algorithms. And one of these is an amazing one for pregnancy that I'm just waiting until we get the actual pump partners, they figure out the pump partners to be able to actually prescribe it. So how do they perform? The AID systems very consistently meet glycemic goals on average for type 1 diabetes. Despite all those devices I just showed you, they have different configurations, they have different algorithmic approaches, and despite that, we see a very consistent finding. The way this is kind of the 7 main algorithms or devices that are approved in the US, and you see on the left the comparator, which is in, I guess, purple, whatever in that particular pivotal trial was done, and then the AID results in the time and target range is in, I guess that's pinkish color. And again, this is time and target range, 70 to 180. So our goals are to try and get 70%, and you can see they all do that. On average, someone will spend 1.5 hours to 2.5 hours more per day, each and every day, in target range if you're on one of these devices. They do lower A1C and pretty consistently across groups. Of course, the individual outcomes are going to vary. These are based on study populations. They all have a different trial design. But I would say, you know, a lot of data, when you look at it, and we're out in the real world using it with real people, the clinical trial data doesn't always match your real world experience. This is actually not the case for these devices. And across studies, you see this over and over again. This is just one of the particular devices looking at some of the main outcomes, time and target range and time less than 70, comparing it to the real world data, and you'll see very, very similar numbers in terms of improvements in each one of these outcomes. So the lived experience seems to reflect the clinical trial experience. Who would benefit? Well, at this moment, there really hasn't been shown to be a demographic that does not seem to benefit, meaning from a glycemic standpoint, if you look across ages, this is just one of the pivotal trials, that they'll see a significant improvement in time and target range, regardless of age. They're approved down to age 2. And then I'd like to show this particular one. This is looking at real world data. And what you're looking at here, these 4 lines on the right, these are time and target range as measured by CGM. And you see the bottom group there that's in red, their time and target range is very low at 30% before they start an AID. And the minute they start an AID, you see that time 0, there's a almost immediate change in their glycemic control. And generally these devices within 3 to 6 days will get the person right up to their target. So the acclimation period is quite short. And what I want to just point out on here, the top one is people who are doing quite well, who are at 80% time and target range, the blue line there, and even that group sees an improvement in these devices. But you can see at the end of the day, there's still 4 curves that are pretty separated. The red group that's struggling a bit didn't get as high as the blue group. And so I think a lot of us in the field have been struggling with, well, why is that? And why how can we, is there almost a ceiling that you get to with individuals? Even though the average data that I showed you earlier will show that everyone gets to, on average, to 70%, but it's not true of each individual person, of course. So I think we're trying to work on this. But in terms of who can, whether you have never used a CGM or a pump before, you can still achieve these results. I want to just, again, a nod to Dr. Cryer and his amazing work related to hypoglycemia unawareness. There's been a number of studies, and actually one of the first studies we did before we got one of them commercially approved was looking at whether we could restore some hypoglycemic awareness in individuals using these devices. This is one study by Dr. Rickel's group, who I think was just the last Cryer lecture, if I'm not mistaken. And this is type 1 diabetes people with type 1 who have impaired hypoglycemic unawareness and experience severe hypoglycemia. This was a hyperinsulinic hypoglycemic clamp, one of the tools to look at hypoglycemic responses. And this was before they got AID, 6 months after, and 18 months after. And to just kind of summarize this data, if you give 18 months of AID use, you drastically reduce the incidence of hypoglycemia itself. And then it appears that you can partially restore some of the symptoms that person can use to recognize that they're at risk or they're experiencing hypoglycemia. When you look at epinephrine, that's one of the first responses to the defense of hypoglycemia. There's improved epi response, and then decreased peripheral glucose utilization, which again is a desirable outcome to make sure glucose is available to guard against hypoglycemia. This trial, their main outcome was looking at endogenous glucose production, so another key feature for how do we protect against hypoglycemia. It wasn't particularly changed in this trial, and people who have type 1 have deficits in glucagon. Glucagon is the other hormone that's recruited and initiated for maintenance of normal glucose, and I don't think we're expecting AID would necessarily change that. But I put it here because it's one of the questions that people are working on now. Can we develop systems that have dual hormones where maybe you also can replace the glucagon? And there's a lot of work, or some work going on in that right now. So to summarize, the automated insulin delivery devices increase time and target range across lots of different types of individuals, decreases hypoglycemia, particularly in type 1, and then lowers A1C. So what I just showed you really was about type 1. I want to just touch base on type 2 diabetes and where these devices might have a role. I absolutely do not think they have a big role in type 2. So I think type 2, if you've gotten to the point where you've tried metformin and SGLT2 inhibitors, GLP-1 receptor agonists, and they've had type 2 for a long time, as you do start to get insulin deficiency over time, and they've arrived at the point at which they need insulin, and titration of insulin is still not doing it. Then I think we start talking about whether or not some of these devices might help those individuals. But we just now have our very first one approved for type 2 last month, and this is I'll show you the pivotal trial data for that. It's called the Secure Type 2 trial, 305 participants in the US, adults, and it wasn't a randomized controlled trial. It was really, I guess, a safety trial, 2 weeks of run-in and then 13 weeks of AID use. And this group had a mean A1C of 8.2%. Interesting enough, if you look at it, the CGM use in this population, now this, of course, is a clinical trial, so you're going to attract individuals that have higher technology use, but 62% of them came into the trial with CGM use already. Most of them are on multiple daily injections, and a fair portion are on GLP-1 receptor agonists. The primary outcome they were looking at is whether or not you could reduce A1C, and you see the main outcome here. All participants dropped their A1C from 8.2% down to 7.4%. This is clearly very clinically meaningful. And it's, you'll see, now granted, if you start at a higher A1C, it's also true in the type 1 data, you'll see a bigger drop in the A1C. But this is more notable compared to some of the type 1 data. And then if you look at across a variety of subgroups, they all seem to benefit. I do want to just point out this group here that's greater than 9%. Again, I'm describing who are we struggling with, who would we be maybe finding ourselves in this position of offering this as a potential. They dropped a very significant 2% using this particular device. And this seems to be, you can achieve the results across different baseline characteristics, whether or not it's use of GLP-1 receptor agonists or their pre-study meal dosing. The other key secondary outcomes are to look at time and target range. And in this case, remember our goals here are trying to get 70%. This group is struggling at around 45% coming into the trial, and they got up to 66%. So that's a 20% improvement. Again, we usually generally see maybe 10% in the type 1 trials. So that's quite significant. And then here on the right, of course, if you increase time and target range, are you putting the person at risk for hypoglycemia, right? So are you going after, being too intensive and they end up hypoglycemic? And that doesn't seem to be the case here. On the right here, you see that there's non-inferiority in time less than 70. Again, this group, this is type 2, so they have a little less of a burden of this, so we don't always see that the hypoglycemia is an issue, but it did not change it, which is the outcome you would hope in this population. So I think this data is interesting for type 2. Where I think the field is going is we are really trying to see if we can get better insulins, because part of our big Achilles heel is we have super slow insulin. Insulin isn't meant to be given in subcutaneous. It's generally appearing in the portal vein and acting very quickly. It has normally a fast onset and a fast offset. But we've got slow insulin that peaks at 90 minutes and lasts for 4 hours. And so that element means that you end up with a lot more after eating or postprandial hyperglycemia and then later risk for lows. So we're working on, there's a couple of newer agents that we're getting some grant funding to test to see if we can improve outcomes just using an ultra-fast acting insulin. We're also interested, there's a lot of interest out there for whether or not you can combine these agents with other particularly in type 1, you wouldn't normally be doing SGLT2 inhibitors. They're not approved for that. GLP-1 receptor agonists are also not approved for that. But we all understand that they're being used off-label in these settings at times. And so, and there's some studies on this, but there's more that are coming to explore how these could be used in combination. And then I mentioned earlier, glucagon is clearly a big deficit in people who have type 1. So there's work on trying to get a dual hormone system where you both have insulin and glucagon. And where I think, me personally, where I think that's going to really have a huge role maybe in the management of exercise. And that's still very, very difficult to avoid hypoglycemia in people who are on AID systems. They're absolutely not perfect. People will become hypoglycemic when the exerciser can be. There's a little bit of interest in amylin as another option, but I think glucagon is the one that a lot of people are focused on. And it's been hampered actually more because of the stability of glucagon. It's difficult the logistics of using it and getting it in a pump. So I think some of that has been solved, so they're gearing up for some pivotal trials of that. What our group does, I have the real privilege of partnering with I'm kind of surrounded by engineers that think differently than I do, and it's great because together we come up with a better situation when you've got different approaches to a problem. But we've been working on trying to personalize or adapt the individual, this struggle of how can we not get everyone up to the same amount, and is there an individualization that you need for the different parameters? So we have several NIH grants on that we're working on. Just finished a huge trial that we'll be publishing just soon on this. And so I think there's a role for that. And you can create algorithms that do it for you, that will tell you this is what your new parameter should be. And that's what we've developed. So then the last option is what we're calling fully automated closed loop. We have 2 particular NIH grants on this, and this is where we're trying to decrease the burden of the use of these devices or the daily living experience that you have. And one of that is constantly thinking about when you approach a meal and you sit down, you've got to figure out what you're going to eat, what order you're going to eat it in, how you're going to bolus for it. So we've developed one that you don't bolus at all. And we've taken it home. We just finished that last month, and I'm about to do a much larger trial on that. And that's where someone spends 14 days not doing a bolus. In general, people who are very, very well controlled probably do 3 to 5 individual boluses per day. So this was no bolusing. So lots of work. Our group and others are working on there. So that's our future directions. And let's see. Okay, so why are these future directions? Well, we have limitations. Despite these glycemic improvements, persistent challenges remain in AID use. Cost and access is absolutely one of them. Postprandial hyperglycemia, which is after eating, the high glucose levels that persist, you'll see it across the board in all of the devices. And I mentioned, I spent a little bit identifying that we have a lot of limitations in the subcutaneous insulin action time. Exercise, I'm not showing any of that data. That is a real challenge. And we have another very specific grant that is just focused on that. So I think there's challenges. When it comes to cost and access, I just want to spend maybe 2 slides on this. And this is quite disturbing that the technology advancements that we've seen appear to be increasing healthcare disparities. They don't appear to be lowering it. And there's a couple really notable studies that are being done. These are 2 that were published recently that a lot of people have focused on. I'll just show you some data from the one that was the Medicare fee-for-service. So these are some data in the U.S. For type 1 diabetes, and just looking 2017 to 2019 about the adoption, just the use of CGM and pump, and it's very clear that a gap in technology adoption by race is growing in this time frame, and subsequent studies seem to be validating this. There may be lots of reasons why this is. I want to just highlight one that is being looked at, and that is what is the role of the provider, healthcare provider in this. And one key role is people don't know about devices or don't know that it's an option for them or are encouraged to use them. So the act of recommending diabetes technology, if it's appropriate, again, I'm not saying that diabetes technology is appropriate for everybody. That's not the message I want to convey here. But it is for certain individuals. And so this was a study looking at whether there are implicit biases in providers for recommending diabetes technology. And this was looking at the T1D exchange, again, the major US registry trial for type 1. So these are pretty experienced institutions that are oriented toward the management of type 1. And they took 109 adult and pediatric providers in the exchange. They randomized them to assess based on stylized clinical vignettes and have them determine whether or not they would recommend diabetes technology in a given situation. And these vignettes had different insurance and different names and different proxies that they were using for racial and ethnic identity. The results suggested that almost 2/3 of the providers had an insurance-mediated implicit bias, meaning that individuals who had private insurance were offered more tech than public insurance. 1/3 of people, 34% of the providers, had an implicit racial ethnic bias. Non-Hispanic names were offered more tech than African American or Hispanic names. And I think this type of data is quite startling and really makes us pause when you think about how you're approaching your individual patients and helping them decide what's right for them. I don't think this is alone the issue, by itself an issue, but I do feel like it's within my control, I would say. So that's why I wanted to highlight this. So to switch from there to one of the very specific applications, there's many different scenarios where we might use automated insulin delivery, but I wanted to focus a little bit on inpatient use. It might be relevant to all of us that find ourselves in lots of different disciplines taking care of inpatients that are struggling with glycemia. So one of the issues with inpatient is, are CGMs valid in the hospital or not? Complicated patients where a lot of things are happening. This is a really nicely done study looking at, again, this metric that I mentioned earlier with CGM, something called a MARD. How different is the CGM reading from some standard that you're setting out there? And generally, in the outpatient setting, we'd like 10% or less if we can. This is in non-ICU inpatients. They were getting a MARD of 12.8%. That's considered pretty good. And this is just a plot showing a point of care fingerstick glucose compared to a CGM reading. And if you're closely aligned, you're in zone A or zone B, and you're generally trying to get those numbers well into the 90s. Between zone A and zone B, that's 99% correlation there. So 99% of the values are there. So I think that's some important data. CGM readings, I didn't really show you this data, but they are very dependent on what the actual blood glucose is. So the lower the value, the more variable the reading can be, and that's obviously a problem. We'd like them to be even more accurate when the person is low. But we find that's true. The MARDs are higher in the inpatient setting, just like the outpatient setting. And then someone who's anemic is problematic. So we use a cutoff of a hemoglobin less than 7. We get worried about the use of the CGM and the accuracy of it in the hospital setting. Renal insufficiency doesn't seem to make a difference, and that seems to be playing out in the outpatient setting too. When you look at inpatient use in the ICU, an even more unstable environment, some of this data is also showing MARDs in the 12%. So, and that zone A, zone B in the 98%. So it's better than you might think that it is. And I want to just show you first what some of the data. This is sort of meant to be an eye burner slide, and sorry about that. But this is some of the CGM use in inpatient setting, and it's not very impressive. It doesn't look like that people end up in a better situation if they're using just a CGM in the hospital. There's a lot of interest in this, of course, during the early days of the COVID pandemic when CGMs offered an avenue where you didn't have to go in and do a finger stick, and you'd have to do that multiple times a day. So there was a lot of the FDA kind of not look the other way. They had a formal description for what they would allow us to do for inpatient setting because they're not officially approved for that. But the actual data are a little disappointing. I'm not saying that you can't find where there's some reduced reoccurrence of hypoglycemia, fewer patient contacts in the context of COVID was an important outcome, but the actual glucose outcomes are not impressive. I think the most interesting trial that's just come out was looking at the TIGHT trial. And again, this is just, I'm not talking about AID at this moment, I'm just talking about the use of CGM. And you know, our ADA guidelines right now in the inpatient setting is to try and get glucose values that are between 140 and 180. This is consensus driven, I would describe that. This is not RCT driven. And you know, we know that people whose glucoses are higher rates of infection, probably thrombosis, and then we're balancing and get that risk of hypoglycemia. So we're at 140 to 180, and a couple really seminal studies in inpatient setting really question the role of tight glycemic control because of this hypoglycemia limiting factor. The nice sugar trial is probably the most important one, or most notable one, most important, but most notable one that really showed increased mortality when you're going after really tight targets in the hospital. So we backed away from that. This trial that was just presented decided they wanted to go after a CGM-based, more intensive target. And they were going to go after 90 to 130. They randomized people to use a real-time CGM and go after 90 to 130. And then the control group would be the standard target, 140 to 180. And they did have CGM, but it was blinded. So they were usual care, but they could use the blinded CGM as an outcome. And this is just in inpatients in type 2, 166 patients randomized. A1C baseline was 8.9%. Most of them receiving insulin before they had come into the hospital. Their primary endpoint was the mean glucose, and there was no difference. There was no difference in that mean glucose between the intensive therapy and the standard therapy. It looks like it's numerically, but it's not statistically significant. If you look at the glucose ranges, I highlighted what their goal was. Their goal was to get between 90 and 130. Well, they didn't really. The numbers were quite low there, and the two groups ended up same percentages in that range. If you look at the higher ranges, of course, 140 to 180, the intensive group that's shown here in blue, they did have a higher percentage in that target range by going after a lower rate. But the primary outcome was not significant. A key secondary endpoint, of course, is hypoglycemia. Again, this group certainly is at risk for that. This is CGM less than 54, so this would be quite significant hypoglycemia. And there was no difference between the two groups for that. When you look at hypoglycemia adverse events, there's some question whether the intensive group had a few more actual finger stick readings without clinical severe hypo. So this data is, again, not very convincing that CGM is the method to get to tighter control in inpatient setting. So of course I'm going to introduce the concept of AID. Maybe the issue is that you're just using the CGM by itself and not combining it with a smarter method to deliver insulin, because fundamentally it's the insulin that's more of the culprit in achieving the glycemic ranges you'd like. This is a randomized trial of a AID that's not available in the US. Actually, this is a UK one. This is inpatient non-critical care type 2, and you see a very significant improvement. This is no longer a time in target range. This is a mean glucose, and the red is if you gave an automated insulin delivery device. They're also known as, there's many names for them. They're also known as closed loop system or even artificial pancreas, which I cringe. That's the term I used to use a lot, but it's really not that. This group, there was a 24% greater time in range if you did an AID in this setting. When you're looking at inpatients who are receiving nutritional support, generally tube feeds, you can also see a very significant reduction, up to 30% greater time in target range if you're combining the CGM with an insulin pump and an AID. So these are two well-done studies that I think really focus a lot of attention on inpatient use. All of these were outside the US. We partnered with Emory and Stanford to go after formally using it in a study. We first did a pilot just of 18. It wasn't a control group at all, just because we all understand the inpatient setting is very complex, and we're going to have a device that the nurses are now going to be responsible for, and we were trying to really have it be focused on the nurses giving the boluses and trying to manage the device. So we did a pilot to just see how that would go. And just so you see what it looks like, this is a person in the study. They're wearing a CGM, which is here, and then this is the one we used is a disposable piece that's changed every 2 to 3 days. Here it has no tubing associated with it. It's called a patch pump. And then there's a device that's locked up at their bedside. We just put it in the narcotics cabinet and locked it up. That is what's managing it and having the CGM listen to the pump. So that was the setup, and then it was displayed to the nurse's station for where their glucose was. We also had to do a lot of work. I don't know if I didn't ask the question if you all have Epic. Seems like everybody has Epic. Okay, we all love Epic, don't we? Yeah, it's great. And so we had to figure out how to get it into our system so the nurses could very easily decide if that is a validated CGM or not. I don't know what your practices are here. I didn't get a chance to ask last night, but we do at UVA, our standard is if someone comes in with a CGM, they need to once a day validate it. And so they just have to do a point of care, and we have a flow sheet that just says to the nurse, yes, it's validated or it's not. So that was part of that. I'll show you one anecdotal. Again, this is just a non-controlled study. This is a hospitalized patient who has a UTI who has type 1. And what I'm showing you here is the graph. This is the glucoses. And both the green is a CGM reading here, and this red and blue are finger sticks. And what happened in the trial, this is when they were on just insulin injections, and then they got enrolled in the trial. They were put on an AID, and then they had to go back to MDI. So it's very clearly that this middle section is very different in terms of what happened to their glycemic excursions. Now this is type 1, so these are much more validated in the use of type 1. We're working on understanding type 2. We had 2 type 1s, and the rest were type 2 in our pilot. So if you look at the overall data, this is by day. This is from, they could be up to 10 days in this trial. Again, tiny numbers here. It took a while. This is time and target range in green. We're trying to get it 70% or more. And we were on day 3 till we could do that. This is us learning. We were all kind of, oh, let's not be too aggressive. And I think we just didn't set it up as aggressive enough. But this is why we do pilots. And it has little adaptation. So we were encouraged by this. So we, and our mean time and target range was 68%. So from here, we felt that we successfully implemented the use of AID, or at least showed we could do it. Remote monitoring, we set that up in the documentations and the validation. And so then we approached the NIH and we received funding. So starting later this month, our 3 sites, Emory, Stanford, and UVA, have a randomized trial to compare AID versus the control group. The FDA really wanted us to do real-time CGM. I kind of wanted usual care, but the control group will have real-time CGM. The data I just showed you before would suggest that the controlled group just having a CGM shouldn't make a difference based on our available data, but we will see. So that's, and this is non-ICU. Hopefully it'll be a lot of type 2s. Not hopefully, it will be a lot of type 2s, but we will include some type 1s. So I say to summarize, CGM use is increasing with improved accuracy and options. AID systems consistently increase time and range and lower hyperglycemia in type 1 and may have a limited role in type 2. I did show you that data, but I think it's a narrower group that you might use it in. The inpatient data on CGM is mixed without at all convincing evidence at this point for superiority, but inpatient AID data I would say is emerging. We have continued advancements are needed to address the ongoing suboptimal performances in postprandial hyperglycemia, and then certainly equitable access and healthcare disparities that I only just glanced off in this discussion. So coming back to our chasm here with technology, well, how we do. I want my old pancreas back. Well, again, I kind of cringe because I used to always call it the artificial pancreas, but it's not that. We know that. It's not that. And do these systems really alleviate the worry about hypoglycemia? I think they go a long way. I wouldn't quite give it a check mark. I think it's still on the plus minus. Food flexibility, we're definitely working on that. It's certainly better. No blood sugar testing, that's been great. The CGMs really, their trends are so good. Even though I feel like people should check probably more than they do, but people can go weeks to months without checking. Not that that's recommended, I shouldn't say it that way. And then sports without distraction, I think we're still working on that. But absolutely, they perform amazingly well at night. They really, really, really let someone have a good night's sleep. And that's an easier time of day because there's not a lot of the disturbances, as the engineers call it, meaning meals and exercise. So it's much easier at night to get a real achievement. So. This is our group here at Center for Diabetes Technology. Most of the people in this room are, we have a lot of psychologists we work with and engineers, and then a few, and mathematicians. And these are your slides. So thank you very much. And I turned my watch off, so I'm not sure if that clock is correct, but hopefully we have a few minutes for questions.
So I was just wondering, with the AID inpatient, did you, even with your small group, did you have issues where, let's say the patient was going for imaging and then everything has to come off and then everything has to go on? Like practically, how do you foresee kind of managing those issues?
Yes, exactly. So the practical reality of it is part of what we really want to test with the feasibility. They were regular old inpatients that were going for an unexpected procedure. So if they have a CT or an MRI, you've got to rip the CGM off. We did have, like if they were going down for a procedure, maybe they were doing some cottering, but it wasn't right where the devices were, we could keep them on. So just like how we normally manage somebody who may be going through some kind of surgical procedure or other procedure. If the imaging, the MRI, CT is not being used, then you could use them. What we did do is we felt like once they came back up to the floor, we validated the CGM. So we had our own, we wanted to make sure that we did a finger stick and the CGM and just make sure that was okay since it was still driving the insulin delivery. But yeah, I don't think we've solved all those problems, and there's lots of unexpected things. But it's also so easy to say to the nursing, if something bad's going on, you just rip these things off. They just come off. They're easy to replace. And the little pods that we have, technically speaking, they're only $30. I don't know what the company would charge for them, but that's all they are.
And
so
how much insulin do those little patches hold?
this one holds 200 units. Yeah, and it has a minimal fill of 80, so depending on, and you change it every 2 days or so, 2 or 3 days.
Yeah, I can speak on this, okay. So I had a question regarding the inpatient use that you mentioned too. Was there any specific training for the nurses
Yeah.
to learn how to use it?
Yep.
And was it a formal evaluation on the added burden?
Yes.
Workflow?
Yeah, that's the question. Our NIH trial has a whole entire aim that's that. What happens to all the different stakeholders within, not just the nurses, the pharmacists, the administrators that have to work together for this to happen. So we'll be formally evaluating that. In terms of training, it took me, it took me 15 to 20 minutes to train the nurse and about what they had to do. We took on the responsibility of setting up the device, right? Because we would normally, as an endocrine consult, decide what the settings would be, right? I don't think that we did insert the 2 devices. I was amazed at how many nurses says, "Can I do that? Oh, that looks easy. I could do that." And we're really interested in. We weren't specializing like who we were targeting. We were kind of on any floor. We'll see if that plays out in the larger trial, but. Expressing an interest, oh, this is interesting. And it's very, the insertion of them is really straightforward. It's not solved yet. I don't mean to say that. Definitely not. It's complex.
Thank you so much for your talk. That was great. I just want to stress about one of the slides that you showed where the use of CGM really helped improving the time in range, but not in all of the patients' categories. Like those who had a lower time in range did improve significantly, and it was still less. So this is stressed to, at least to me, that there are a lot of other factors that are playing in the blood glucose control, and that's maybe why in the TITA trial, the CGM use did not have significant difference. My understanding is those centers did not have any standardized way of reviewing or adjusting insulin delivery while the patients were wearing the CGM. So when we use a CGM, I mean, it's nice to wear it, but if we don't do something with the data on on demand, on right away type of manner, we will not have an effect. And the proof is when you use an AID with the CGMs, you had significant improvement in the time in ranges. So I don't want to underestimate the use of CGM, but maybe we have a lot of factors. And this is maybe where my question is, where do you see the use of artificial intelligence in the future integrated in all of the available devices, like maybe detecting activity, food intake, any body stresses, all of these stuff?
Yep, that's precisely what we work on every single day, and it's that question. Because in the TITA trial, as you said, that was exactly true, that the individual sites didn't have a standardized method for adjusting the insulin dosing. And at the end of the day, it depends on the insulin dosing, which is why, from a research perspective, we've been going after standardizing that. And this trial I just mentioned is a standardization where all you say is push a button and say, what should the new settings be? And it tells you them. And if you consistently apply that, maybe you'll, I'm not saying it's going to be perfect, but maybe it changes the outcome. So your point is valid. It's not that CGM may not, it's just using it in the right way. And my proxy for that is the use of the AIDs, which we still have to learn that for sure. So the kinds of things we're doing now is there's something called reinforcement learning, which is one of the machine learning techniques that I think we all kind of iteratively do as a physician. Well, this didn't work, so we're going to try this. This didn't work, we're going to try this, and particularly around meal bolusing. But you can, there are AI methods that optimize that rapidly. And so that's the part we're about to launch is a new phase of that, to use that kind of data. Yeah, and we'll see how the data will show us if it's better or it's not.
So I got a question and two questions. The first one is in regards to your comments about the values of 180 in the hospital has been by consensus. And some of the more 180 has been in data of macrophages function, and that's what the 180 came from.
Yeah.
But nobody knows between 180 to 140 what happened. Do you have this as a second aim in your new trial and determine it?
Yeah.
And the second comment and question, what is your comment about glucose variability in type 2? Because certainly the insulin pumps may not have, and it has the end of when you use many other medications, but glucose variability also occurs in type 2, certainly postprandial.
Yeah.
And I would like your comment and see if what do you think about glucose variability in type 2 and the complications, and if pumps has an effect. Yeah,
so the glucose variability, I think we're limited because we don't have great measures of that, to be frank. And if you look at a common measure for that would be CV, and it doesn't always show us what I think we need to know. So I think we don't always have a great measure. So then when you look at the trial, I was trying to link the measure to the outcome. There's some hints there. That's how I would say it. So I think but it's still a hypothesis that it is related to the outcomes, and the more we can address that, we might see a difference. And your point about the other relevant findings for how we divide, macrophage function, for instance, how we define the target range. Our current R01 that's looking at the inpatient doesn't have any, it's pure glycemic numbers. Yeah, we're not being sophisticated in terms of what's driving that. We will, when you get to the devices, they're actually, the one that we're using, we're going to set a target of 120 or 110. So it's not actually, it's not like I don't know if you all use Glucomander here, but it's not like we can set something like a range, 120, 160, or 140, 180. It's got a specific target. So we're already deviating from what's considered standard.
So, one quick question then, if there's time. You brought up this postprandial hyperglycemia. With the massive increase in AI, is it going to be possible, maybe using a standard plate, that somebody takes a picture with their phone and it says, oh, you're about to consume this many calories, and the pump releases insulin?
Yeah, so there's someone already has that. Not that the pump automatically releases insulin, but that you have the picture, and it's a picture of the plate and a determination of what's on there. So people have absolutely worked on that. We did a study with the watch that was just identifying the motion of eating. And so the motion of eating triggers, oh, they're eating. And so that didn't work out so well, except then a company snatched the watch and now it's been buried. And so anyway, that didn't, I think there's a lot of interest in trying to make those things a little more identifiable. It does become a real issue about, our biosensors and what are we willing to use to drive this. Like in exercise, lots of people are trying to use accelerometers to say, oh yeah, they're exercising, better adjust insulin based on that, and linking those two. That work is still emerging, but I do think it's also highlighting how does the person feel about all the things that are on them, that are reading them and then reacting with a critical response, which is insulin administration based on that. So there's a lot of interest in it. And I do think you're highlighting one thing, which is a lot of, when we get to, maybe you mentioned this too, about what these ceilings are, or actually I think it was you, food choices still matter, still really, really, really matter. However you want to look at it, they do. And so, no AID or picture of the plate fixes that.
Thank you.
Thank you.